common in India because we eat a lot of green leafy, but we cook them. Is the screen visible?
Yes, sir.
Okay, so let's begin. So first of all, my thanks to Dr. Anita and Dr. Gujral for doing this day in, day out. It's not an easy task to be there and handling all the logistics along with the IT team. Thanks to moderators for doing this, Dr. Rajiv Kumar for joining as chairperson, and all the PG students whose participation we look forward to. So for the outline, I have 5 discussion cases, fairly simple ones, day-to-day practice issues that we have to sort out. So we're not going to anything high-flown. And some of them will have CBC parameters to guide the diagnosis, some without, so that I want you to make your visual impression as well. And for the PG students, please interact. If you have any queries or doubts, I'll be happy to answer if I can. And wherever required. So when we gave you the cases, I gave you 5 cases only, but I will add relevant information I've already added in this particular PowerPoint to supplement and make for better understanding. And when we finish these 5 cases, there's 10 quick quiz cases at the end, just one slide each, just to refresh some common things and occasional uncommon ones. So again, like emphasizing, please interact and participate when we discuss the questions. So just a background of 5 to 6 slides. For an accurate CBC report, we require the numbers. The automated counters give us those numbers. The histograms, we have flags by the instruments. And what we're going to do today is the peripheral blood smear. It's a sort of a gold mine sometimes for the diagnosis. When nothing else helps you, the peripheral film many times clinches the diagnosis. And it is a window to what is happening inside. And inside is our body. We are dealing with hematology. So the bone marrow, whatever is happening, the peripheral smear is a window to that. So we can, without doing a bone marrow, sometimes kind of enter the bone marrow and understand what might be going on. This is a picture from British Journal of Hematology, and somebody put up all alphabet letters in a case from MDS, myelodysplastic syndrome. And there's a series also on numbers 0 to 9. So these are white cells, but all the cells actually talk to us when we look at them in a peripheral smear carefully. And sometimes the cells express love, sometimes they smile at us, sometimes they look like dinosaurs, sometimes things may be fishy. So jokes apart, we now deal with a lot of analyzers, 3-part and 5-part analyzers, which give us enormous information in these times to sort out most of our hematology issues of the CBC. We also have now, for many years now, almost image analysis. So the human eye is being replaced by the image analysis by the instruments, auto analyzers, giving way to analyzers which will scan your slide and give you a differential, even a red cell output report, and sometimes even an opinion. Cell vision is one model, and there are many others. However, in spite of all these advancements, I recommend to all of you this 2-part analyzer that you all have. Comes free. We just need to use it carefully to understand what is going on with our blood. So let's begin with the case studies. So case 1, I think Dr. Annie will handle this. So Dr. Annie, can you tell me the diagnosis, suggest a diagnosis for this case? A 65 years old male with fatigue for 1 month.
Yes, sir. The blood pressure looks like a microcytic hypochromic anemia.
Right. Any further? Would you like to stretch your neck out further?
Yeah, and also I can see a few polycytes, such as pencil shaped RBCs, teardrop cells, ovulocytes, erythrocytes occasionally.
Right.
And I can see a normal neutrophil on the blood picture, and the thrombin and the platelet count seems to be adequate.
Right. So what's your possible diagnosis?
Microcytic hypochromic anemia.
Now, again, I would just like to add on a microcytic hypochromic anemia is our morphological opinion on this slide, right? I want to know what's the possible clinical diagnosis coming out of this. What do we tell the patient?
Yes, the differentials for microcytic hypochromic anemia can be the deficiency anemia or anemia chronic disease,
right?
Or thalassemia minor,
right?
Or it can be sideroblastic anemia or electroporation disease.
Right, very good. So when you said thalassemia minor, what about thalassemia major? Is it not microcytic hypochromic?
Yeah, it is, but there are a lot of target cells that are not seen.
Yes, so the morphology will be very off. So from all these 5, in this case, what would you suggest as a diagnosis?
It can be deficiency anemia.
So your most likely diagnosis is iron deficiency anemia, and that's correct. So what you see is a lot of microcytes, some of them very, very empty, some have slightly more hemoglobin, but if you see there is a variation in hemoglobin content. Some are very empty, some have some more hemoglobin. This is called anisochromia. And also you said very correctly, you see a lot of microcytes with a lot of poikilocytes. So it's anisopoikilocytosis. You have these pencil-like cells, you have some teardrop cells here, and not targetoid cell, not very clear here. And it's a picture showing you a lot of variation. So my next slide is the same case, but any comment on this particular field?
I guess polychromatic cells also.
Okay, an occasional polychromatic cell here. Very good. So that means the marrow is responding to the anemia and throwing up immature RBCs. The reticulocyte count is likely to be higher in this case. Any other comment? Anybody else would like to contribute? Any other disease?
Was the patient on therapy?
No, the patient was not on therapy.
Because in pure iron deficiency anemia, the reticulocyte count will not be high.
No, so the reticulocyte count, when we say high, we are talking about a count that needs correction. So after the correction, you will usually see that the retic count will be within a range that shows your marrow response. Any other comment on this field? Not related to RBCs. Okay, so let me just cover that. This cell is a small lymphocyte, very thin cytoplasm. It's a small lymphocyte. So this actually acts as an internal control for our morphology. So if you have any doubts on are these microcytes or not, most of these RBCs that you see are smaller than the nucleus of this cell. And that's a very good clue that you're dealing with microcytosis. Let's say you're in a peripheral area, do not have any indices to go by. Look for a small lymphocyte.
Naveen sir, please unmute yourself.
Are you able to see my screen?
Yes, sir.
Okay, the current had gone off in our complex.
Yes,
Just connecting through the mobile. Sorry for that. Okay, we come back to that case. Was this complete or did it break through this? So anyway, I'll repeat this. So on this slide, what you see is a small lymphocyte, which if you look at, we look at it as an internal control or internal calibrator. The nucleus of the small lymphocyte size, and you compare that with the red cells, or the red cells are smaller than this. This confirms this is microcytosis, and because they are significantly smaller, there is good degree of microcytosis. This MCV will be in the 60s, 61, 62, or something like that. So that's clear iron deficiency. So diagnosis was iron deficiency, and Dr. Annie gave the differential diagnosis very well. We talked about iron deficiency, thalassemia, both straight and major. We have anemia of chronic disorder, which often is normocytic normochromic, but can be microcytic hypochromic, lead poisoning, and sideroblastic anemia. How would you differentiate them, Annie? Dr. Annie, how would you differentiate?
So I would like to have the CBC parameters and
Right,
as well as the
right.
iron studies.
Okay.
For,
Right. So we are on to the next point. Investigation to decide which iron studies would you want to do?
I would like to have transferrin saturation for
Right.
ferritin, then proper iron binding capacity, and serum iron levels.
Serum iron. So you can also do zinc protoporphyrin and serum transferrin receptors in some centers if that is available. So what would happen to serum iron? Low, normal, high?
In this case, it will be low.
Low. Serum ferritin?
Ferritin will be also lower.
Low, right? Transferrin saturation?
Saturation will be lower, and
right.
PIBC will be higher, and as
PIBC will. Right. So very true. So we have less iron, so serum iron is low. Transferrin saturation because there is not enough iron to bind to transferrin as a transport protein. Ferritin is a store form that goes first. It's knocked out first actually, and your TIBC, your binding capacity, increases when you do not have access to iron otherwise. And zinc protoporphyrin is a good test if available in limited centers. So whenever iron is deficient, zinc comes and binds to the porphyrin. So the more deficient the iron is, zinc protoporphyrin increases. So that's a good clue. And transferrin receptors to make do or to capture as much iron as possible in a state of deficiency, they increase their synthesis. So that's high. So 3 parameters reduce, 3 high, and that's your typical biochemical set. Any management tip for this particular patient?
Yes, I will also, since this is a 65-year-old male with iron deficiency, I would like to consider for any cause for chronic blood loss or any underlying malignancies have to be ruled out.
Excellent. So if this was a 7-year-old, you would give iron supplements and leave and follow up. But for a 65-year-old, you would want to investigate for a source of blood loss, maybe benign or malignant. And at this age, we would also want to rule out a malignancy. So a stool occult blood, maybe with endoscopy if indicated, upper or lower. So that's the message from this case, that elderly male with iron deficiency anemia not to be left alone. 7-year-old child, a lady during pregnancy, a lady with heavy menstruation, you can just work on a therapeutic trial and sort it out. But this patient requires investigation before you can start treatment, but investigate for the cause. Okay, so very well discussed that. So just a background to this, and we'll go on to the next case after a few points. So when we look at anemia, your question is looking at a CBC, is there anemia? If there is anemia, my next question is which type? And the indices help you, and we know these are the indices. And in terms of practical usefulness, MCV takes the cake. MCV sorts out most of our anemias very well. MCH select conditions, MCHC virtually, you don't really use it as a decision-making parameter except for one condition, and that is hereditary spherocytosis, where an MCH raised is a clue that there may be spherocytes in the blood smear. Otherwise, MCV is the most useful of the 3 indices. So what are we missing when we talked about these indices? Annie, we talked about red cell indices. Are we missing anything?
RDW.
Very good. So we are looking at a parameter which was added in 1980 to 85, red cell distribution width, a very important parameter to help us decide the type of anemia. So let's just look at this quick picture here. So when you are looking at a normal red cell population, you get a normal red cell distribution. It's based on the mean corpuscular volume at a 20% discriminator. Normal value is about 11 to 15. So this one has 12. The red cell population is normal. Whenever a red cell population has variation in volume, which is size or shape, and hence both, the volume varies. The variation in volume gives rise to a high RW. So if your RW is high, you know that the red cell population has variation. So let's look at the value of RW illustrated in this case. If the patient's normal MCV today is, let's say, 92, if he develops iron deficiency because of a nutrition or a blood loss cause, his MCV falls to 82, and he presents to you with, when you do a CBC, he'll have a normal MCV because normal MCV is 80 to 100. Right? So he's dropped MCV of 10 femtoliters, but his MCV on the CBC is still within normal range. So at this point, if you do a look at the RW, I'll take you to the next one. The RW in this case is 17.4, which means even though the MCV is normal, the RW is detecting emergence of a new microcytic population with variation in volumes. So that is the value of RW. Any book that you're reading in these times which does not talk about RW, please do not read it further, because RW is a key parameter in deciding anemias in these times. Okay, so our case has these indices. So as you would see, it fits in very well with the blood picture that you saw, anemia, which is microcytic, and hypochromic MCHC is also low, and a high RW. So that goes with your anisopoikilocytosis that you saw. TLC and platelets are absolutely normal. There is no problem that side. So a typical classical microcytic hypochromic anemia with a high RW. You really need to confirm with the expensive biochemical test. In daily practice, you can actually go with this and say this is probably iron deficiency unless proved otherwise. And like you said very correctly, old age iron deficiency, please investigate for a cause of blood loss. Do not just treat, unlike the younger ages. So I want to give another scenario again to Annie. I wanted to interpret this case for me only from the indices. CBC is done for health insurance. Those are the values. What's your comment? Sorry, can you please repeat that? I couldn't hear that. Any of the other participants?
No.
Okay, so we have a hemoglobin which is normal.
Chat many have answered thalassemia.
Yeah, thalassemia trait. A lot of people have answered, which is right. So you're dealing with a hemoglobin which is normal. You have a microcytosis, but you have a normal RW. Again, TLC and platelets is normal. So your second differential, which was thal trait, comes in here. Microcytic hypochromic anemia with a good degree of red cell response and a normal RW tells you this is possibly thal trait. So you must remember, whenever you diagnose iron deficiency anemias, that few microcytic anemias could be thal carriers, especially because we are in India, and most of India distribution-wise we are covered with thal, beta thal to be more precise, and other combinations as well. So we must not forget about a thalassemia trait as a differential diagnosis, and we need to sort this out with these values and some other tests. And remember, I said in the last slide, few microcytic anemias, and that's one misconception we must need to remove. And I did that with that case because that patient was not anemic. No anemia, really. He had hemoglobin of 13.5. So no anemia, but microcytic hypochromic with a normal RW. It's classical thal trait indices, and you will find this more in males, because in females, your menstrual losses, pregnancy, lactation, nutritional issues, they may be more anemic. So they when they have thal trait, they develop some sort of mild anemia, but males generally remain either borderline or even normal hemoglobins. So this is the classical thal trait picture. And if you do the Menzer index, which is the mean corpuscular volume here divided by your red cell count, comes out to be 10.9. Any value less than 13 suggests possibility of thal trait. And in this patient, the hemoglobin A2 was 5.7, which is diagnostic of beta thal trait, with the normal being 1.5 to 3.5. So the message here is microcytic hypochromic. Look at the index as well. Look at the RW. That's a good clue whether you're dealing with a thal trait or an iron deficiency. There are over 40 available indices like these, different calculations with interpretations, but please use the Menzer, most frequently used and most helpful. MCV by RBC ratio less than 13, suggestive of thal trait, not confirmatory. More than 13, maybe iron deficiency. Just a table. I'll just leave it for a few seconds for you to just read. It helps you to distinguish iron deficiency from beta thalassemia carrier state. So both have low hemoglobin, but like we just saw, you could have a normal hemoglobin in beta thal carrier. The RBC response is much higher in beta thal trait because of the compensatory marrow response. MCV is low in both, MCH low in both, but RDW is high in iron deficiency. It's normal or slightly high in patient with beta thal trait. And if a patient with beta thal trait develops iron deficiency, it may be difficult to figure out from the indices alone. You may need an SPLC then. So the Menzer index here is more than 13, less than 13 in beta thal carrier. So just a comment towards the end. In children and in pregnant ladies, the Menzer index may not be very helpful. So you need to look at other methods to sort it out, because here hemodilution and the normal values may not be equalized, and the hemoglobin values and the red cell count in children is a bit different. So the Menzer calculation is a bit tricky in these two scenarios.
There is a question in the chat box that should we
Yes,
suggest HPLC for all Menzer index less than 13?
Ideally, yes. Ideally, yes. If you have it available, please. So there are, like I said, you'll find about 85 to 90% of the times this will come out to be positive, and the rest of the times your HPLC may be negative. That's fine. Allow it to happen, because there are other scenarios where indices may be thalish, but your A2 may be normal. But you're not going to miss out a thal trait. like this. So if you pick up a clear Menser index coming less, microcytic population, REW not very high, good idea to do an HPLC and devise an HPLC. Electrophoresis in the types available in limited centers, throughput is not good, accuracy is not that great, so HPLC is best advised. So comments on these two cases, Dr. Annie, this one is very familiar. What about this one? Okay, this one seems like a classical iron deficiency. What about this one, Dr. Annie? Any comments? Anybody else?
Normocytic caprices.
Great. So this is the mistake that we also make and made earlier. This is the case. The case on top is a patient with beta thal trait. So the point I'm emphasizing is, in spite of the microcytosis, good degree of microcytosis, you are calling it normocytic normoglobin. That's the common thing that will happen in daily practice. It is sometimes you might pick it, sometimes you may not. And the reason is because hypochromia in iron deficiency is very, very marked. Hypochromia here is actually mild to moderate sometimes. So that is missed. And because the cells look alike, REW is not very high, and the hypochromia doesn't catch our attention, we sometimes report this off as normocytic normochromic on the smear. But if you look at the values, you'll find MCVs of 60, 65, 67. So that's one scenario. Thal trait is difficult to pick up unless you have an experienced eye. And I can say we've also missed thal traits like this unless you look at the indices. So depending on the smear to give you a thal trait diagnosis can be tricky. However, if you find a lymphocyte, small lymphocyte in this field also, you'll find most of your RBCs are small. That's a good clue to look at the indices. A final word on this case, we talked about serum ferritin, but remember serum ferritin is also an acute phase reactant. So in patients with iron deficiency who have inflammatory conditions, your ferritin may not help you. Your ferritin may be high because it's reacting to the inflammatory.
Dr. Naveen, one question. Dr. Naveen,
We go on to case 2. So Dr. Pragya, who's handling this?
Dr. Naveen.
Sir.
Can you go back to the previous picture?
Yes, sir.
Yeah, this one. The one on the top left.
Yes, sir.
The thalassemia.
Yes, sir.
Why? If I see this smear, I will not say hypochromia.
Yes, sir. Sure. So if you see the smear, usually you would report it as normocytic normochromic, or you will probably say an isocytosis 2+, poikilocytosis 1+, and hypochromia either normal or even mild or not. And that's the problem with thal trait diagnosis of the smear.
I'm not sure, but I think it's pretty normochromic.
Yes, but it is mostly microcytic still. So
Yeah,
hypochromia is
but
yeah.
it is still normochromic mainly.
yeah normochromic. There are few cells which show you more hypochromia than that, but that's it's a tough ask to say on a blood smear. So these are often missed. So sometimes you report this as normocytic normochromic as you put the slide under the microscope, and then you suddenly see the values and say, okay, MCV 67. Then you look at REW and then you think this is thal trait. So that's a common issue, and we don't expect a thal trait diagnosis coming from smear often. It's the indices that matter most there.
I just want to say something.
Yes, sir.
Long time back, I do not know how many people have read Williams' book of hematology. I do not know if the students read that. There was a panel of four pictures, and the caption said that experienced hematologists were shown these pictures, and they had to decide whether there was hypochromia or not. And
right.
there was a huge difference of opinion.
True.
There was a huge difference of opinion. So in this particular case, at least if I am looking at the smear, it does not matter what the indices say. I will not call this a hypochromia.
Yes, sir. True, very true. So, in fact, mild hypochromias, even when we have even an MCV of 72, 76 with mild hypochromia, you will call this as normocytic normochromic. And that's the fact we have to admit that our eye cannot pick up something as small as this, which the counter will pick up. Dr. Rajiv, any comments?
No, that's it. Thanks.
So there is a question, can we report this as microcytic blood picture?
Which one?
So the
This
picture
one
you
again?
showed. Yes, so the upper left. Yeah, this
Yeah.
one.
So again, remember we are not looking at this in isolation. We have to correlate with the. So if I were to say this, if I were to see this as under the microscope, my first impression is probably normocytic normochromic or maybe mild poikilocytosis. That's it. But then we have the CBC printout with us that shows you as an MCV is less. Go back to the smear, look for a small lymphocyte, and decide are these microcytes or not. So we must learn to.
What do you think, Dr. Thakkar? What do you think? I think there are some microcytes, quite a few.
Yeah, there are microcytes. There are enough microcytes.
Even though there are so I would say that this smear has normochromasia and also microcytes.
Yeah, microcytes. And poikilocytosis is mild, not too much.
Yeah,
See some of these
fine.
cells.
Yeah,
Cannot
correct.
target cell here. So I probably should have transplanted a small lymphocyte picture also here to show the difference. But that's one to look for. A small lymphocyte nucleus is a good clue to the degree of microcytosis. Like I said, iron deficiency will not trouble you much. These cases will. And that's where we need to marry the morphology with the counter analysis.
So Dr. Aparna asked, should we depend on indices for commenting on hypochromia?
You must. Now, in these cases, so when you say commenting, then I'm actually looking at a report when you are looking at the indices separately and you have the same smear. In this smear report, if you do not see hypochromia, do not report that. But once you have your indices, your opinion should go what the indices also suggest.
Yeah.
So we must learn to use the two together, but not. I will not correct this report to hypochromia because the MCH is low.
Right.
Okay, thank you, sir.
So, Dr. Rajiv, any queries or shall I move on?
No, yes, please move on.
So case 2. Case 2. Who's dealing with this? Dr. Pragya?
Yes, sir.
Yeah.
38.
Yes,
35 years, female with fatigue and or steady gait for 2 weeks. She is pale and has mild icterus. laboratory investigation shows pancytopenia with hemoglobin 6.5 gram percentage.
Right.
Total leukocyte count 3200 per cubic millimeters, and platelet is 90,000 per cubic millimeters. MCV is increased, that is 118 femtoliters. Red cell distribution width is also increased, and TLC is within normal range.
Right. And what's your impression from the smear?
In this smear, there is a single hypersegmented neutrophils with 7 nuclear segments,
Right.
and one RBC shows 1 macrocytes and macrovalocytes. However, there is no lymphocytes. It looks like macrocytes and the macrovalocytes, but there is no lymphocytes. We cannot see lymphocytes for the comparison of size of the RBCs.
Right.
And a single platelet is seen in this picture.
Right. So
And
what's
this
your
is a non-chromic RBC.
right? So what's your final diagnosis?
It's macrocytic megaloblastic anemia.
Right. So
Did you say macrovalocytes also?
Yes, one in more left, I think.
yeah,
That-
these are macrovalocytes.
Yes.
Even these cells which appear normochromic to you because the normochromic cells are somewhere of this volume, the normocytic ones, even these
Yes.
are all macrovalocytes. So they're large and oval.
Yeah.
And like you said, your hypersegmented neutrophil. How many segments? Let's count. 1, 2, 3, 4, 5, 6, 7, 8, and 9. There's an overlap here. 9 segments. So even six with even 1 with 6 and beyond is hypersegmentation. And in this background, I'll take you back to the history. I want you to correlate the history and revise your diagnosis. You're close, but I want some more addition to it.
In history, there is honesty gate.
Yes. So what does that tell you?
It could be due to vitamin B12
Right.
deficiency.
So once you have a neurological element involved with it, B12 deficiencies for sure. This patient may be having B12 and folate together,
Yes.
but you can be sure about B12 because you have neurological symptoms which are not seen in folate deficiencies. Right. So in your CBC, if you notice there is pancytopenia,
Yes.
there is clear macrocytosis, REW is high, which goes with our smear, showing variation in volumes. So this is a classical megaloblastic anemia because of B12 deficiency in this case, could be having additional folate deficiency. We can't say right now. And this, the combination of a macrovalocytic picture along with hypersegmentation neutrophils is megaloblastic anemia and nothing else. No other condition will give rise to this combination. So we talked about the diagnosis. What's your differential?
Differential is macrocytes are seen in these pictures with the increased MCV. The differential diagnosis could be macrocytic non-megaloblastic anemia.
Right. So although we say once you see macrovalocytes and hypersegmented neutrophils, we are dealing with megaloblastic anemia for sure. But other causes of macrocytosis you have to rule out. They will not show you this combination. They may show you an occasional hypersegmented neutrophil, but not the oval macrocytes. So in that case, your non-megaloblastic macrocytosis, liver disease, blood loss, reticulocytosis, renal disease, thyroid disorders will all come in. And alcohol is a common example in India and must be in Nepal as well. And so you have, in those cases, you have often hemoglobin is maintained very well, 14, 15, MCV of 116, but RDWs are normal. So they just have a membrane excess that gives rise to the macrocytosis because of metabolic problems usually. And they do not have a folate B12 problem, no maturation defect, and so on. So what's the cause of icterus in this patient?
In this case, there in the megaloblastic anemia, there is ineffective erythropoiesis. So erythroblast will die. Some of the erythroblasts will die in the bone marrow.
Excellent. So it
There
is excellent. So in this case, anemia with jaundice, with sometimes tipped spleens, which these patients may have, does not mean a hemolytic anemia. Important to understand that the ineffective erythropoiesis element gives rise to a hemolytic anemia-like picture because you have increased LDH, you have jaundice, which is mainly indirect, but it's not per se hemolytic anemia. So the cause of icterus, very rightly said, is ineffective erythropoiesis.
Okay.
Now, yes, sir.
Can I ask, what do you understand by ineffective erythropoiesis?
the erythro.
So if you say ineffective erythropoiesis, there must be something known as effective erythropoiesis. So what is ineffective erythropoiesis? You are right, in this particular case there is ineffective, but you should know these terms. So read up.
Due to vitamin B12 folate deficiencies, they cause there is a impaired DNA synthesis. Hence, there is cell proliferation and cell division is affected.
Right.
And so in these conditions, there is a cell cycle is hampered. So
No, actually, all the things are not required. When you say ineffective erythropoiesis, you're simply talking of an erythropoiesis which does not lead to the delivery into the peripheral blood of normal numbers and normal kinds of RBCs. Therefore, there is anemia. If the erythropoiesis is effective, then you'll find everything normal in the peripheral blood. If it is ineffective, then something is happening in the bone marrow. Cells are dying faster, are dying before release. So ultimately, what comes out is the whole process of erythropoiesis was not effective. Did not succeed in doing its job. That is how you should look at it. Don't go to the details. I do not know what, Dr. Kakkad.
I fully agree. Yes.
So what you're saying is about the DNA synthesis and cell cycle. All that is fine, but then go into that. Without going into all these details. Broadly, this is what it means. Anyway, go ahead. Yeah.
Okay. So which investigation would you like to consider, Dr. Pakya, to confirm our case?
I would like to see reticulocyte count.
Right.
Which is megaloblastic anemia. It is lower than the normal range, and serum B12 level, serum folate levels,
Right.
and serum homocysteine level,
Right.
and liver function test, thyroid
Right.
function test,
Okay.
and bone marrow examinations to see the megaloblastic changes.
Right. Excellent.
But before that, you'll do a marrow, bone marrow. Isn't
Yes,
it?
before.
Yeah.
Yes, sir.
Because in this particular case that has been given to you, it is such a nice case. As Dr. Kakkar said, this case looks. I mean, you can straight away say that it is megaloblastic anemia from the PS. So you will do a bone marrow examination also. You can do folate assay and B12 assay. Bone marrow examination is very important to confirm megaloblastic anemia, because that is the most important. That is the diagnosis in this case. And Dr. Kakkar, what in this case?
Yes, sir. I'll go on further. So in this approach, you would look at the history examination, and history of vegetarianism is important. And remember, although we say folate deficiency is not that common in India because we eat a lot of green leafy, but we cook them a lot. So we do not eat them raw, like raw salads, mostly like the West. So folate deficiency is not uncommon. B12 deficiency is underreported clearly. So in our CBC, we saw macrocytic anemia with a high MCV, raised REW. TLC and platelets are normal, but you can get pancytopenia in late stages, like in our patient. Would you do iron studies, Dr. Pragya? It looks like a classical megaloblastic. Would you do iron studies?
Yes, sir.
Yes. What's the reason? Because there is no evidence of any microcytic picture in the peripheral blood.
Yes, sir. To look for mixed nutritional deficiency.
Or another nutrition deficiency. Anybody else from the postgraduates? Your comments about doing iron studies in this patient? Okay, so normally we do not think that iron studies will be important, but I'll just show you one case report, and there's a series of 8 patients. There are more, where if you have a concomitant iron deficiency, the megaloblastic anemia can be masked. So in this case, our megaloblastic anemia is frank, but in some cases, you may not have enough evidence of macrocytosis in the peripheral blood. And if you have dual deficiency, we've seen peripheral blood showing clearly microcytic hypochromic anemia, marrow showing good degree of megaloblastosis. So one deficiency sometimes can mask the other. So it's good to, once you're looking at a nutritional problem, cover your iron, B12, folate together. Do not work in isolation, because if I'm nutritionally deficient in one, I'm likely to be nutritionally deficient in the other as well. And that's why the point that Sir made about doing a bone marrow, very important. I've not in this collection, but I've seen a 7-year-old girl with an MCV of 63, hemoglobin of 6, presenting with pancytopenia. We thought actually it was a leukemia, considering the age and the pancytopenia, and she had bleeding from the gums. So we thought maybe an M4 leukemia coming up. Next day, her marrow showed frank megaloblastic anemia. Periphery showed completely opposite picture, and she was iron deficient as well. So mixed deficiencies, one morphology may mask the other. A good point to remember. Okay, so would you do a bone marrow? We've kind of discussed this, but there are some centers or some proponents who say once you see these macrovalocytes, MCV is 120, hypersensitivity neutrophils, why do a marrow? Do a B12 folate acid, whatever is to give the treatment. Any comments? Anybody?
Yeah. Can I say something?
Please, sir.
Can you go back to that paper by Jenny L. Spivak?
Yes, sir.
You know, in the abstract, the first line, I think the student should also hear. In 6 patients, 8 episodes of anemia associated with folic acid or B12 deficiency were unaccompanied by macrocytosis.
Right.
So these cases, just from the first 2 lines, were different from what Sir has shown, Dr. Naveen has shown. Please remember that. So there was B12 folic acid deficiency, but they were unaccompanied by macrocytosis. That was because of the underlying iron deficiency. Am I right, Dr.
Yes, sir. Yes, sir. Yes. So regarding the bone marrow, it's good to do a bone marrow in all cases of megaloblastic anemia, especially if your patient is in the older age, maybe 45, 50 plus, and he has features which do not fit into a typical nutritional anemia. He is run down, he is fatigued most of the time, he has a liver and a spleen which is more enlarged than a megaloblastic would do, because you might be dealing with an underlying MDS or even a malignancy. So leukemia, sometimes they consume a lot of folate in dividing population. An leukemic leukemia, which is not yet in the circulating cells, are not yet come out in the PBF, may be sitting in the marrow, consuming your folate, giving you a B12 folate-like picture in the peripheral blood, and you may miss out if you do not do a marrow. So it's a good idea to do a marrow and be sure of this diagnosis. You must do B12 and folate assays. A red cell folate is better than a serum folate, but it's not available in most centers. Methyl malonic acid, homocysteine will come up. They'll be raised in B12 deficiency. I'll talk about this role in the next few slides. And if you're suspecting pernicious anemia, good to look at anti-IF antibodies. Again, pernicious anemia is underreported in India. Clinical suspicion is not really done. Okay, so this is a typical bone marrow picture of megaloblastic anemia, a large sieve-like chromatin, open chromatin, these large megaloblasts. Now, most of these will not mature to form mature red cells. They will die off in the marrow. That phenomenon is called ineffective erythropoiesis. And in effect, in megaloblastic anemia, what you have is ineffective hematopoiesis. So your giant metamyelocytes, these are normal myeloid precursors. Some of them also die. Your megakaryocytes will also die. Hence, you get pancytopenia in the later stages. But the name comes from the word megaloblast. The megaloblastic anemia comes from these large megaloblasts from the bone marrow. It's not from the macrovalocytes. It's from the megaloblast in the bone marrow. Just a comment about functional B12 deficiency. I'll just highlight the key point of this paper. So this can lead to functional B12 deficiency, but with apparently normal serum levels. It is suggested by raised levels of methyl malonic acid or homocysteine, other metabolites. So again, we are talking about a B12 deficiency in which your serum levels are normal. So our investigations sometimes fool us. So if you have a full panel, you may find a good answer. Going on to another paper which comes to a finding which Sir mentioned just now. This paper looked at diagnostic accuracy of MCV in B12 deficiency, and from AIIMS Raipur 2017. That's their gist. They screened 501 adolescent girls. Prevalence of B12 deficiency was very high. Like we keep on saying, it's underreported. If you look for it, it's more than what is reported in the Indian population, 60% almost. They saw anemia in 43%. So you could be having a hemoglobin of 12.5, an MCV of 110, and your serum levels may be low. Anemia may not be there still. Now, more surprisingly, they saw the raised MCV in only 10.4%. So what is our impression? Macrocytic anemia, megaloblastic anemia. You may not even have MCV high in 90%. There was not MCV high in 90% of these cases, and they were B12 deficient. Half of them with anemia. So important points to remember, and I'll just recap these in these two sentences. We think megaloblastic anemia always has a raised MCV, and we also think that megaloblastic anemia due to vitamin B12 deficiency has low B12 levels. Both of these are now questionable, which means you can have megaloblastic anemia with normal MCVs, you can have normal B12 levels, and still have megaloblastic anemia. So that's functional deficiency in which methyl malonic acid and homocysteine levels will help you much more. So all I'm trying to say is megaloblastic is not that